right, looks like we have everybody here. We're going to get started. Good afternoon, everybody. Thank you for joining us. My name is Jennifer Walsh. I'm a senior media officer with the Institute of Medicine, and on behalf of the Institute of Medicine, I'd like to thank you all for joining us, those in the room and those of you who are joining us via the web. This is a discussion of our new report that was just released, Beyond Myalgic Encephalomyelitis, Chronic Fatigue Syndrome, Redefining an Illness. And I'm sorry for butchering the name. This report is now available and it can be downloaded as a free PDF along with other related materials that go along with the report at www.iom.edu/ME CFS. This will be a 1-hour briefing unless we run out of questions beforehand. And we will start with some opening remarks on behalf of the committee members and some background on the report. And then I will open it up to questions. Those of you who are in the room can ask questions, as well as those of you via the web. And with that, let me introduce Rick Ertman, Director on the Board of the Health of Select Populations from the Institute of Medicine. Thank you.
Oops. Again, I'd like to extend my welcome to all of you who are here today at the Keck Center, and also those of you who are joining us by the webcast. As you heard, my name is Rick Erdman. I'm one of the board directors here at the Institute of Medicine. Our board was honored to be responsible for the management of this particular report, which we are releasing today. And that report is entitled Beyond Myalgic Encephalomyelitis, Chronic Fatigue Syndrome, Redefining an Illness. Myalgic encephalomyelitis chronic fatigue syndrome is a mouthful and is commonly referred to make it easier as ME CFS. But it's a serious, complex, and debilitating condition that imposes a burden of illness on millions of Americans all over the United States and all over the world. The cause of ME CFS is unknown, and a diagnostic biomarker is yet to be identified and validated. Over the last several decades, numerous and diverse case definitions and diagnostic criteria have emerged from a limited knowledge base, which has led to much confusion and contradiction about this disorder. So the Department of Health and Human Services, along with 5 other federal agencies, asked the Institute of Medicine to form a committee to define diagnostic criteria for ME CFS based on current scientific evidence as well as clinical expertise, and also to propose a process for revalidation or reevaluation of these criteria in the future, to develop an outreach strategy for dissemination of these criteria to health professionals all over the nation, and to consider whether a new name for this disease is warranted. This report today is the culmination of the committee's attempt to examine those questions. I am very pleased to introduce the committee chair, Dr. Ellen Wright Clayton, who is joined today by 2 fellow committee members who she will introduce. In a few moments, they will present the key findings and recommendations from their report. But I would like to take a moment to thank the entire committee for work on this very, very difficult task. Their efforts were also supported by an outstanding team of project staff led by Cece Mondaka-Shaw and included Kate Meck, Jonathan Schmelzer, Adriana Moya, and Sylvia Doja. Finally, I would like to thank our 6 sponsors: the Department of Health and Human Services, the Agency for Healthcare Research and Quality, the Centers for Disease Control and Prevention, the U.S. Food and Drug Administration, the National Institutes of Health, for their ongoing commitment to improving the lives of patients.
To be able to share our findings with you on this project. These are our committee members who all worked very hard, were very devoted to ensuring that this task was done with complete attention to the evidence base and to develop criteria that we would use going forward. I also want to point out that we had a very rigorous review of our report. by a number of experts, many of whom you will recognize on this process. This is an inherent part of the Institute of Medicine process, and so I want to thank them in particular. Well, here's an outline of my go through this relatively quickly because I want to have as much opportunity for conversation with you all as we can. I'm going to say a little bit about the background and context. You've already heard a little bit about what our statement of task was, and then I'm going to talk about our key recommendations. Then we'll talk a little bit about pediatrics and comorbidities going forward. The background is this. This disorder is a complex, multi-system disease that causes a great deal of disability and debilitation for millions of Americans. We don't know the exact number because this disorder is radically underdiagnosed. Probably only 10% of those who actually have the disease are diagnosed. As you've heard, there have been multiple definitions over time. And that diagnosing this disorder in the clinical context is a challenge. And that we know that patients often struggle for years before they get a diagnosis, and that they often face a really frustrating process, particularly as clinicians often dismiss their concerns. And so this is really very important going forward. And we know that it is burdensome and costly both individually and socially in terms of so let me go back a second. Our committee was charged by a number of people who you've already heard. These slides are all available on the web so you can read them, but I want to get to the meat of this more quickly. Well, and here was our charge. Our charge was to develop evidence-based diagnostic criteria to address the needs of health providers, patients, and their caregivers, considering the various definitions and looking at particular subgroups to the extent that we could do so. We were also importantly to pay close attention to the concerns of patients and their advocates. We were to recommend whether new terminology would be adopted, and then importantly to recommend an outreach strategy, because I'll jump ahead here just a minute, and we think that this disease can and should be diagnosed by any clinician, not just the specialist in this disorder, but any clinician who takes care of patients ought to be able to diagnose this disorder. This is our process. We actually, you all know about the committee selection process. We had 5 committee meetings with information gathering, and 2 of them hearing public testimony from patients and caregivers and clinicians. We had lots of deliberation, drafting of report. We then went through report review and approval, and now we are releasing this report today. To give you a little bit more detail, we had 5 meetings with 2 public sessions. We got some input from the CDC multi-site clinical study of CFS. We did not have access to the information from the NIH P2P workshop. We had consultants. And I would also emphasize, we got almost 1,000 comments from patient advocates and providers. We carefully reviewed each comment that we got from all of these sources. So almost 1,000 comments we went through and considered at great length. And then we conducted a comprehensive literature review going back, as you can see, quite a while, back to 1950, looking at what's been known about this particular disorder. We built upon the work that has been done in the past. We built upon the definitions that have been used in the past, and we took all of that information into account. Our initial literature research turned up more than 9,000 articles, which is a lot of articles. We then looked at the quality of the articles, as is typically the case. in literature reviews going forward. And we did more targeted research on a number of major symptoms, including post-exertional malaise, orthostatic intolerance, neurocognitive symptoms, sleep-related, and symptom clusters, as well as many other issues. We narrowed this down to actually a relatively small number of high-quality reports. And then in addition, patients sent us 1,291 articles, all of which we reviewed in depth and considered them and coming up with our criteria. So our key messages are that this is a serious, chronic, complex, multi-system disease that can often profoundly limit the health and activities of affected patients. This is not a figment of their imagination. This is not somaticizing. This is a common, all too common, complex disease that needs to be diagnosed. And we concluded, based on our review of the literature, that a thorough history, physical examination, and targeted workup are necessary and typically sufficient to determine a differential diagnosis and make the diagnosis of this disorder. So our first recommendation is that this disorder should be diagnosed when individuals meet the criteria. I'll say a little bit more about this in just a minute, but this is really important. We also think it's very important that there be a new ICD-10 code so that we're not stuck with benign myalgic encephalomyelitis or neurasthenia or chronic fatigue. This needs its own diagnostic criteria, which will be helpful not only for these patients, but frankly for the research enterprise going forward. Here are our criteria. And this is the essence of this disorder, that there be a substantial reduction or impairment in ability to engage in pre-illness levels of occupational, educational, social, or personal activities. It has to persist for more than 6 months, be accompanied by fatigue, and is not the result of excessive exertion. We also require post-exertional malaise. I'll say a little bit more about that in just a minute, as well as unrefreshing sleep. It's interesting to note that there are no particular diagnostic criteria on sleep studies that are helpful in this area, but every patient complains about this. And so we thought this was really important, and that at least one of the two following manifestations needs to be required: either cognitive impairment or orthostatic intolerance. How did we come up with this? The data and listening to what patients told us. These are symptoms that the overwhelming majority, and if not all of these patients have. Many of them have objective manifestations that can be identified, and that these are absolutely essential to make this diagnosis. We created a diagnostic algorithm that's also present, in which I'm not going to go into it in detail, but basically it's just another way of representing what we already talked about. It's essential that clinicians assess severity and frequency. These symptoms are persistent, they are severe, they can come and go, but they are something that people experience over a prolonged period of time. And that it's important, in order to make the diagnosis, that these symptoms be present for 6 months, because there are a number of fatiguing disorders that actually resolve on their own within 6 months. I want to back up here and make a point here that I know I'm going to make later, but I want to make it here. The fact that we have 6 months to make the diagnosis is important, but there is another important issue here. Patients who have these symptoms need to be treated, have to have their symptoms addressed, even if they haven't persisted yet for 6 months. So these patients have real symptoms, they deserve real care and real therapy, whether they meet the criteria for this disorder or not. So I just want to make that point. Absolutely essential. There are a number of other manifestations that frequently appear with this disorder, but they are not always present, and they often manifest in a variety of different ways. Their presence supports the diagnosis, but they are not required for the diagnosis, in no small part because they don't affect all these people. I've already made this point that if people have symptoms, they need to be treated, whether they meet the diagnostic criteria yet or not. So Dr. Bateman will say a word about what this is going to mean for clinicians. This is you.
There we go. Good thing he's sitting next to me. We are hoping that these diagnostic criteria provide a very clear path for clinicians to make the diagnosis. It's a fresh start. You'll be hearing about the descriptive name. The diagnostic criteria are evidence-based, which means they will be very convincing to physicians, and I think people will be able to start to see this illness. And we wanted to make sure that the symptoms that have been previously maybe overlooked by clinicians are put front and center in this diagnosis. I think it's going to make a big difference, not only for primary care, but also for specialists.
Great, thank you. Our second recommendation is that the Department of Health and Human Services develop a toolkit appropriate for screening and diagnosing patients with this disorder. The current tools that are available are too complex and too difficult to use in a busy clinical practice. And I think it's pretty clear based on the evidence that it is possible to develop a more focused set of tools that can be used by any clinician to make this diagnosis. And when I say any clinician, I mean any clinician. I mean primary care, emergency medicine, all kinds of subspecialists. Any clinician ought to be able to make this diagnosis, and that we think this is absolutely essential that this occur. We also recommended that we were asked to talk about reevaluation of these criteria. One of our points here is that the science is changing dramatically. We learned a lot from the data that already exists that allowed us to come up with these very clear diagnostic criteria. We expect and hope that more research in the near future is going to allow the refinement of this diagnosis, allow the development of tools that are effective for particular patients. We're hearing a lot of talk about precision medicine. What precision medicine means in its final words is that we have tools that allow us to diagnose the specific disease in the individual and devote specific therapy that addresses their needs. We are hopeful that this research will go forward. What that will mean is that we will need to reevaluate these criteria, and we want to ensure that this occurs in no less than 5 years, no more than 5 years. Sorry, I said that wrong. That this really needs to be done, and it needs to be planned for, because this is an area where the science is really changing, and we are, desperate that these patients get the benefit of the latest science. Okay, here's the big one. We, as a group, spent a lot of time thinking about what we ought to do about the name, since we were asked to consider whether new terminology was needed. And let me tell you what sort of drove this, besides the fact that we were asked. It's clear that chronic fatigue syndrome does tremendous disservice to these patients. I mean, if I don't hear another person say to me, I'm chronically fatigued too, or that is this a real disease, it will be too soon. I mean, we got to get over this one. Similarly, myalgic encephalomyelitis doesn't describe the essence of the disorder. It is, and so although I know many people advocated for it, it actually doesn't apply to what we defined. So what we did decide to do was to focus on coming up with a name that identifies the major criteria for this disorder, which is post-exertional malaise. And but that doesn't say things to most people. So what we decided to call it was systemic exertion intolerance disease. The essence of this disorder is that if patients with this disorder engage in exertion, cognitive, emotional, physical, whatever, that their symptoms are made much worse and often for a prolonged period of time. That is the essence of this disorder, and we want to name it for what it is. Now, the reason we picked this name is that there is a long history in medicine of coming up with names that define the central symptom. And they do that particularly when it's not clear exactly what the etiology is or what the subclasses are. So what we wanted to do was to make clear that we have a new definition which builds upon the definitions of the past, but which is distinct and which focuses on what is the central element of this disorder. So you can call it SEID. I mean, that's what I call it. So, because you don't want to say that all those words, but the essence here is that we wanted to focus on what this disease is and say that it is, that this is what these patients experience. And so that's the name. Now, Peter's going to say a little bit about, Dr. Rowe is going to say a little bit about PEDS, and then we'll wrap up here.
Thank you. As Dr. Clayton was mentioning, the review of the literature on pediatric ME CFS or SEID really emphasized pretty wide prevalence. We think there are reasons for that, among them being the different case definitions that have been used and the tendency of physicians to diagnose component parts. So, for example, the preference for something like postural tachycardia syndrome rather than ME CFS. But in any event, it's a relatively common problem in pediatrics, also a complex multi-system condition that can have profound effects on the social and educational development of adolescents and young children. It is one of the most common causes of prolonged school absence, and it is time to put to rest the notion that this represents either school phobia or school refusal. The point is that it isn't that these young people don't want to go to school, it's that they can't. The pediatric evidence base was much smaller than the adult evidence. And while we had a number of papers, a reasonably good number of papers on autonomic manifestations and some on the cognitive problems, there were none on using, for example, the 2-day cardiopulmonary exercise test as a way of documenting the pathophysiology. We had 6 papers that were very interesting to review on immunology, none of which addressed anything that the other papers were addressing. So we need a much bigger scientific base to understand the illness in children as well as adults. We concluded that there was sufficient evidence from the scientific literature that orthostatic intolerance and autonomic dysfunction are common in pediatric ME CFS, that the neurocognitive abnormalities, while not present at baseline when patients are tested in the supine position, they will emerge when patients are tested under conditions of orthostatic stress, when they're brought upright, or if another another condition is like distraction is introduced. There's clearly a high prevalence of profound fatigue, unrefreshing sleep, and post-exertional exacerbation of symptoms, just as in the adult papers. And the evidence is strong that ME CFS can follow acute infectious mononucleosis and EBV infection in a percentage. We tackled the issue of the duration of illness for pediatrics as we did for the adults. We felt that the illness was similar in its overall symptoms, that we didn't need a specific pediatric definition, and we required a duration of 6 months in order to allow those patients who are improving after post-viral illness many of them will get better over the next few months before 6 months have elapsed. That will ensure that those who meet the criteria also have a more severe form of the illness. But as has been emphasized by other pediatric groups, we wanted to be clear that this 6-month duration criterion should not interfere with initiating advice, management, and care of the patients, and that can begin as soon as they enter the doctor's office. So that is a brief summary of the pediatric findings.
Thank you. I want to say a word about comorbidities, which is that that past definitions have often said that if a patient has something else, then they can't have this. Our conclusion is exactly the opposite. If they meet the criteria for this disorder, they have it. And part of our thinking about this is that many patients have more than one thing. And the idea that these patients, if they have something else, can't have this is just crazy. So our attitude about this is that if they meet the criteria, they have SEID. If they have something else, then that diagnosis ought to be made and it ought to be treated. But that it should not preclude a diagnosis of SEID unless the comorbid condition explains all the symptoms that the patient has. That is extremely unlikely. So the point that we want to make here is that it is incumbent on the clinician to make the diagnosis, to think about comorbidities because they are common, and if there are comorbidities, to diagnose them and treat them, but that their existence does not preclude the diagnosis of this disorder. So we think that's an incredibly important thing. These are, we listed the comorbidities that have been identified in other definitions and didn't come up with our own, but we think this is a really essential issue. It is possible to have this disease and something else. Areas that deserve further study. There is so much research that needs to be done. I mean, it's just astonishing. Lots more work needs to be done to study the etiology, pathophysiology, and effective treatment. Because of this paucity of evidence, we were unable to define subgroups or even to define the natural history of the disease because there really aren't good longitudinal studies for the most part. There are some, but not enough. So more research is essential. In terms of dissemination of the diagnostic criteria, the audience is just about everybody, to tell you the truth. We want to get to key decision makers, obviously, including primary care providers, but frankly, any other care provider who is involved with the treatment of these patients. If they will just open up their eyes, they will realize that they are seeing these patients and they need to make the diagnosis and provide them with care. I mean, that is, the bottom line. We also realize that there are other audiences as well. I mean, particularly in the case of kids, the K through 12 educators and college health systems need to recognize this disorder. That we also are obviously speaking out to many other organizations in this field. And then obviously we want to reach out to professional societies because they will have a major role to play in influencing the practice of their providers. And we came up with a lot of different things. You can read the report. Obviously, we want to thank all of our funders. We want to thank the speakers and the consultants and the reviewers who I think were really devoted to making this the best possible product that it could be. And we also wanted to thank the people involved in the FDA Voice of the Patient because, as you'll see, looking through the report, we cited their work like crazy, as well as all the work that we got from the various comments from patients. I also want to thank the staff, hear their names, and I think we're done. But our goal here, we wanted to set out. We looked at the evidence. They drove our development of criteria. We think this is a diagnosis that should be made. We talked about how to make it. It is critically important, and that we think that's absolutely essential. There are lots of questions that we suggest to providers so that they can elicit the history that's important for this disease, so they can know to recognize that that's what they're seeing. But the evidence, the scientific evidence, the evidence from the patients, the advocates, the clinicians was really clear. And so building on that and on the work of the many people who have been involved in treating this disorder for many years really drove our decision making. And it is our fervent hope that the result will help these patients. Thank you very much.
And thank you. So now we will open it up to questions. So if you're in the room, if you can go to a microphone on either side of the room to ask your question. And if you are asking a question via the web, there is an area to ask a question. Type in your question underneath the video viewfinder and hit submit, and we will receive that question. Those of you who are asking a question in the room and on the web, I ask that you please identify yourself and your organization before asking a question.
I'm Chris Williams, and I am Vice Chair of the Board of the Solve ME CFS Initiative. First of all, as a patient, I want to thank the committee. I have been sick for 6.5 years, and this is the best thing that's happened to me in that time. So I really want to thank everyone involved. Prior to serving on the board, I spent 30 years in the federal government working on health policy. Half of that time on Capitol Hill working for the Senate Majority Leader, and the other half at ARC. And at ARC, I was the Director of Communications, which involved the dissemination of information to physicians and other clinicians. And I guess my big question to the committee is, where do we go from here? And how do you see this report being used by professional societies, by HHS and other parts of the government, because I think this is a tremendous step forward and a tremendous platform to build on. So I'd really like to hear some of the ideas about how we move on from here.
Well, I'll make a couple of comments. One interesting comment is that JAMA and Annals of Internal Medicine have viewpoints today on this, on this report. So that will be, I think that will be pretty high profile. We certainly had the pleasure of briefing the sponsors of our report about what I can honestly say that I think they heard what we had to say. No, clearly we're going to have to reach out to professional organizations. Clearly we're going to, clearly there's going to be work reaching out to organizations like yours and many others. And so there will be, and we have to do something about ICD-10. I think there are a number of things to do going forward, but we've really, I think this is a pretty bully pulpit for, for this disorder, and I'm hopeful it makes a big difference. Do you guys have anything to say?
I just had one comment about the fact that this is probably the most complete synthesis of the scientific evidence that's been put together. And I think one thing going forward will be that it'll identify for researchers and scientists gaps in the literature that they can attend to, and that will ultimately have some benefit for patients. We also think that at the level of a clinician, this will be a much simpler, more streamlined process that will help with people getting a diagnosis at an earlier point. Now, how to make everything happen at the clinical end was a little bit beyond our scope, but clearly there have to be many more efforts at education so that physicians feel comfortable doing this. There are far too few specialists to handle the volume of patients who are affected.
Change is not easy in any system, especially complex systems, but I think we have about as good a foundation as we could possibly have to jumpstart this process. And then at some point, very soon, the work of this committee will be over. But I'd like Ellen to maybe mention what resources will be available through the IoM educational materials. And then it really is up to all of us to get to work and be supportive, work together, and see if we can get everybody on board so that we can use this as a very good foundation for going forward with research, funding, and everything this group of people need.
So I want to give a shout out to our amazing staff who have already created FAQs, who are in the process of creating a guide for clinicians that is going to be simplified to help them, implement this. I think that it would be very helpful to patients to, be able to go to the web and get a download of what this is so they can take it to their doctor and say, look, this is what I've got. And this is the IoM saying that this is what I've got. So you're right. I mean, the baton does pass from the Institute of Medicine now, but we have tried to make passing that baton as smooth as it could possibly be.
And I'd just like to emphasize that those materials are going to be available at www.iom.edu/MECFS, as well as today's slides that were used for the presentation.
My name is Gregorio Meraz. I'm a reporter for Televisa News Network from Mexico. And I would like to ask you if you know how many people have died or is impaired due to this syndrome. Also, if you know what are the causes that trigger that syndrome, and if you found a previous investigation either here or someplace in the world with similar cases to these ones.
Well, I don't think we know how many have died. Maybe you all do, but I think we just don't have the data. I think that with regard to the question of a resource like this, no study has ever been done like this. I mean, with this just extensive discussion of the data. I mean, so I think this is actually unparalleled. There have been many, very thoughtful discussions about what this disorder is, but none of them have published quite the analysis of the literature that this one has.
And do you have any idea of what triggers that? Because we do understand sometimes it's young people or mature people. What causes that?
Well, first of all, that was beyond our statement of task. I think the only thing that we know with certainty is something that Dr. Rowe has already said, which is that EBV is a major trigger in children or in adolescents. But I think beyond that, there's so much work that needs to be done to sort of figure out what makes this happen. Lots of things have been claimed to make it happen, but at least from what we saw, the only solid evidence was about EBV.
Thank you.
Okay, and we'll go to the next question over here.
Thank you. Robert Miller, 30-year patient and advocate, in which I now have SEID. Based on what we have for experts in the field, and the fact that this information is going to get disseminated to, many more general practitioners, other doctors, specialists, I would expect that there's going to be a huge influx of patients. And so how in the world are we going to be able to initiate research and catch up to be able to treat, because there's no approved treatments for the illness? So I know that there are representatives here from other federal agencies, and so my question would be, how are they going to ramp up or gear up to be able to address treating, whatever it's going to be, 50% more people or 80% more patients coming into, right now, what are a handful of experts in the field?
Those are all really good questions. The first thing I would like to say is that step number one is diagnosis. As physicians and researchers become familiar with this illness, I think there will grow out of that a number of efforts to begin to identify treatments. We need a large group of people across all disciplines attending this, and I think that will naturally happen, but it's going to take some time. Second is, I would like to say, as a clinician that specializes in this and related illnesses, there are many things that can be done to alleviate suffering and to treat symptoms, even some core symptoms, that can be very, very helpful. So there will need to be an effort made to continue getting this information out, bringing other clinicians in to help us with that. And of course, we hope there will be additional drug development as we understand the science.
Just to follow up, do we know? Sorry, go ahead.
Let me just add another point to Cindy's comment, and that is that any physician should be able to treat some of the pain or headache components of the illness, or the insomnia. The orthostatic intolerance treatments for those with SEID are no different than they would be for somebody with a less complicated form of orthostatic intolerance. So there's a lot of information out there, and that will be linked to things in the physician and clinician guide on the IoM website. So I think that part of the need that you're mentioning will be addressed that way.
Thank you. In talking about the other federal health agencies, has there been communication between IoM and any of the federal health agencies on kind of any initial discussion about ramping up research?
We certainly have shared with them what our results are, and we have been breathtakingly clear about the need for more research. I guess what I would say, looking at it through the lens of history, now I'm speaking as my own person here, I think that with the, I think, very clear evidence of this disorder and its characteristics, I think this gives advocates a tool, to act up. How about that for a historical reference? I say, so that's what I think. Go for it. I mean, I think we've given you the fodder.
Okay, and one more thing, and that is, I just would like to thank the IoM committee for pulling this together relatively fast. As a patient, I'm pretty confident that this will kind of ignite some excitement in this field, and we'll get some researchers and hopefully some funding to go along with that. So thank you.
Thank you. We have a question from the web, it looks like.
This question comes from Gabby Klein. She asked, based on the evidence that the panel has found, will graded exercise therapy / cognitive behavioral therapy as treatments be removed from the CDC's toolkit?
I'm happy to, I'm not, treatment was actually beyond the, was beyond the scope of what we were asked to do. So I really can't say what CDC will do. But I do, there is the element of this disorder is that exertion exacerbates symptoms. So that's an essential finding. So what they do with that is up to them.
We'll go to a question over on this side of the room.
Hello, my name is Anita Patton. I've had this illness for over 28 years, and I'm very thankful for all the work that you put into this and what you have done in bringing forth a scientific diagnostic criteria to help the million people that I know have this illness. And another thing I'm wondering is, I've been on Ampligen for over 18 years and have had significant improvement from it, and most interestingly, an ability to tolerate exertion. So I am advocating for the approval of Ampligen because it is the only thing in the pipeline, the only drug that is close or, within reason, and it has been proven safe, and it is quite effective and can be effective if they give it to the right person, I think, with the right broken lab system. But do you have any advice for me as an advocate? Who can I talk to? What can I do to help for the approval of Ampligen? Or do you have any insight? I'm just asking because I'm totally naive. Do you have any ability to communicate or work with the FDA on giving them this information that you have to make that decision?
The only thing I can say is that FDA was one of our funders and they have the report. So
I'll make sure they read it.
I think they already have. So, but in any event, yes, they are one of our funders.
Thank you.
I'm Mary Dimmick. I want to thank you for your work on this report. It shows, and I'm really grateful to you. One of the key issues that you raised is that there's been a dearth of research. Right now, we're using Fukuda, Oxford, and Empirical, even as lately as this month, to issue research findings. Have you said anything in your report or in your discussion with HHS about the need to replace those definitions with a new definition that reflects the way you've conceptualized the disease, not just rename those definitions to be SCID?
That was beyond our statement of task. One of the things about IoM reports is that we get told what our charge is, and then we do our charge, and that we don't go beyond our charge. But I think our work stands on its own, and I think it sends a very clear message. So, and we did discuss the various definitions as part of the report, and it's pretty clear that what we had in mind is different from what some of the other definitions are. So, as we say in the law, res ipsa loquitur, the thing speaks for itself. So I think our work stands on its own.
Take a question over here.
My name is Wendy Shabazz. I'm a patient advocate. So I have a question. Why did you all not go with the consensus of the majority of experts in the field and adopt the CCC, which could have saved $1 million? And why did you not use it as a basis for the definition? Did I say that too fast?
So I think the answer to your question is that we took the CCC definition very seriously into account, and I think that's important. There's been 10 years of science since that was put out, and it's been updated. But we accepted the charge that we were given, and but we, I think, pretty obviously paid a lot of attention to that definition.
Right. Okay. One more question real quick.
Let me just add a comment about that,
sure.
About the CCC definition. A lot of these case definitions we've clearly looked at carefully and tried to build upon the best elements of them. The difference between this and the CCC definition, the initial one especially, was this one was based on the evidence. It took into account many of the same things. Both reports emphasized the primacy of post-exertional malaise, of this inability to do normal activities, either cognitive or physical, without some sort of payback. So we built upon a very good foundation that was laid by the prior case reports. And so we're not being dismissive about them. We think that one of the limitations of some of the prior case reports or case definitions was that they were too complicated for the average clinician to use. They required several symptoms from this column and several from that. This one is much simpler, much more streamlined, and for clinicians, we think it will ultimately make a huge difference for patients. So that will, in the end, get more people cared for and treated, and that's no small feat.
Gotcha. One last question. Are patients able to donate blood now because there was a concern about a possible retrovirus?
Can you answer that? Yeah.
That was a yes, huh?
As far as I know, that has not been an issue for a little while. Yes, patients can donate blood if they choose to.
Okay, thank you.
And do we have any more questions in the room or from the web? Actually, it looks like we have another one from the web.
The question is, how will the information and findings from the committee be, how will you inform doctors of these new proposed changes?
Well, we have made a number of suggestions to our funders about how to proceed with this. In addition, as I've mentioned, we have already posted fact sheets and other things on the internet that are downloadable for free. There will be a clinical guideline or clinical guide soon that physicians can use to make the diagnosis, and obviously that patients can read. So it's, so it's out there for sure. And then, as I mentioned today, I am extremely pleased to say that both the Journal of the American Medical Association and the Annals of Internal Medicine published viewpoints today talking about this report. So I think that we have given some guidance about how to proceed, and we are doing a lot of things to make this more, to make this information more clearly available. Oh, Cindy has something.
I just want to emphasize that this report is accessible and readable, and everyone involved in this illness should get the report and take the time to read it. It's very rich, has many references, also a recommended dissemination plan. I think that it's going to provide you with some very good reading and some reading you can pass on to others.
Any more questions from the web?
Yeah.
One more question. How are the common symptoms of immune and autonomic dysfunction addressed?
We discussed all the data that existed at the time we did the review. So yes, they are discussed. So I would just, that's a complex area, obviously, but they are discussed. And so I would just alert the questioner to look at that part of the study.
Would add that in the guide that the IoM staff are preparing, there will be detailed questions that clinicians can ask to elicit information about immune problems and especially orthostatic intolerance. If people are unfamiliar with how to take that history, that's in there. We list questionnaires that can be used and some of the common features that go along with that condition, such as that the patient might not be able to remain upright and seated during the time of the examination, might have to lie down, might look pale, might have a purplish discoloration of the limbs. So there are a variety of things that are both the physical findings to look for and the questions to ask to get at those problems. So we think this will help improve the history taking that people go through.
Okay, well, it looks like we've run out of questions. So once again, thank you all for joining us here, those on the web. I'd also like to thank the committee members who were here today. And just want to emphasize, I don't know if all of you know this, but the committee members who served on our committee, they served pro bono to complete this report. And once again, just a reminder, you can get all these materials, the report, the slides from today, the materials that the committee members talked about at www.iom.edu/MECFS. Thank you.